decision making for how to select what type of airway or how to predict what type of airway we're going to use for a case. Is there anything else that you guys wanted to touch on as far as airway stuff goes, or does that sound okay?
Yeah.
All right. Matt had mentioned that when you look at the schedule, it's sometimes hard to predict what type of airway we're going to select. And the most common, really, three types of airways that we're going to sort of select are a natural airway, in which case we're going to be using things like supplemental oxygen through a nasal cannula or through a simple face mask. And the way we decide, what type of oxygen supply we're going to use is based on, one, patient comfort, two, the amount of oxygen that we're trying to deliver. So each different type of either nasal cannula or simple mask or non-rebreather will deliver a different FiO2, which is the fraction of inspired oxygen. That's what FiO2 stands for. And so normal room air is about 21% oxygen. And when you put a nasal cannula on, every liter that you're adding is adding roughly, around 5% more oxygen to what the patients are breathing in. But you also need to make sure that you're delivering enough oxygen depending on the type of mask that you're using, for example, to prevent the patient from rebreathing their own exhaled gases like carbon dioxide. So when you guys hand us a simple mask for a patient who's leaving the operating room, and we throw it on and somebody says, how many liters do you want? Well, they actually know how much fresh gas flow you need to prevent rebreathing. So for a simple face mask, it's about 6 liters of oxygen. So that's why most of us choose 6. For a non-rebreather, it's somewhere around 8 liters of oxygen. For an ambu bag, for example, it's at least 8, if not 10. And then you take into consideration with like an ambu bag, for example, how much oxygen you have in your tank and how far you need to go with that patient. So I opt for 8 liters as opposed to 10 because if I'm using an ambu, it's usually because I'm going to the ICU and it's halfway across the hospital and it's going to be a 10-minute walk at least.
Wait, you hook up the ambu to the oxygen? I thought it was just a squeeze, like room air. No?
Well, in a pinch, you could potentially deliver room air, but it's designed it has that little bag on the backside, which is supposedly going to give you an extra oxygen reservoir. In reality, most of the time that bag never really inflates unless you're not squeezing the bag at all. But that's okay, it doesn't have to. It's like when you're on an airplane and the bag may not inflate, but it's still delivering oxygen. But ideally, you're going to be adding some supplemental oxygen to an ambu bag to make sure that you actually have fresh gas flow in it. Patients cannot reliably breathe with an ambu bag attached to them unless you're supporting their breathing. So you need to actually squeeze it because if you just hook it up, they're not going to be able to breathe against that resistance. So that's kind of the real basic overview of supplemental oxygen. So let's say we need to actually help somebody breathe during an anesthetic, so positive pressure ventilation of some sort. The two most common things that we use are endotracheal tubes or LMAs. And so LMA, as you guys probably know, stands for laryngeal mask airway. It's designed to sit above the glottic opening and ideally have a patient breathing spontaneously. You can add some positive pressure to them, but the more positive pressure you add to an LMA, the more likely you are to break the seal of that sort of cuff that's just resting on the mucosa. The harder you blow, the more likely it is to kind of pop that seal off, and then you're at risk of blowing air down into the esophagus as opposed to the trachea.
Positive pressure is a machine that's pushing air into the tube, right?
Yeah, exactly. So when you take a breath right now, it's negative pressure. You're dropping your diaphragm, you're expanding your rib cage, and it's creating a negative inspiratory force that's sucking air in. When we have somebody on a ventilator or an ambu bag, we're pushing air in. That's positive pressure.
So the room would be a positive pressure, or it would be negative?
I'm sorry, say that again?
Like the rooms for like a COVID patient, what is the room? It's positive?
Yeah, so that's actually a similar concept, but completely unrelated to the airway. So positive pressure just means the actual room itself has air forced into it so that if somebody opens the door, things blow out as opposed to sucking in. Okay? So when we say we want somebody in a negative pressure room, it means when somebody opens the door to come in to bring supplies or whatever, that we're not blowing virus out into the hallway. We want it to stay contained within the room.
Yeah.
As far as airway goes, positive pressure versus negative pressure, it changes physiology because it changes the pressure dynamic within the chest cavity, and anytime you change pressure within a cavity of the body, it affects you know, the blood vessels' ability to fill, as well as the heart's ability to squeeze. And so, real quick and dirty with hemodynamics of airway management, if you're pushing air into the chest, when that positive pressure goes in and fills up the chest with air pressure, the blood vessels that are the veins that are draining blood back to the heart are going to collapse, and you're going to get less filling back to your heart. So it's likely going to drop your blood pressure. Whereas if you're sucking air in, negative pressure, that negative pressure in the chest is going to kind of, again, this is an oversimplification, going to suck blood back from the rest of the body to the chest. So it's going to fill those blood vessels, it's going to generally help your blood pressure. So one of the things that you may see us do is, if we've got somebody we're really concerned about their filling, or their preload is another term that we use for venous filling of the heart, like somebody who has a pericardial effusion and fluid around the heart. We're very concerned about maintaining preload, because the second we put them to sleep and start blowing air into their chest, we're going to decrease the amount of blood getting back to their hearts, and their heart's already being squeezed from blood that's outside of it. It's just going to deflate like a balloon. And so changing the ventilation strategy has a huge effect on the hemodynamics of those patients. So back to basics again. So negative pressure versus positive pressure. Negative pressure is what we normally do. Positive pressure is what we do when we change from an awake patient to an asleep patient who's just received medications that not only help them fall asleep, but also decrease their drive to breathe. So opioids, propofol, etomidate, a lot of, well, obviously muscle relaxants. If we paralyze somebody, they're not going to be breathing, right? So there's a lot of drugs that we give that prevent people from breathing the way they normally would. And so we need to help them with their breathing in those cases. So LMA versus endotracheal tube. Well, if we need to deliver a high amount of positive pressure, meaning we're competing against another force that might be working against us, for example, an intra-abdominal surgery or a laparoscopic surgery, where they're going to inflate the abdomen and push up on the underside of the diaphragm. By doing that, we need to fight against that by being able to inflate the lungs by using positive pressure. And so any laparoscopic surgery is generally going to be an endotracheal tube. Okay, because we need to be able to use positive pressure to sort of push against the insufflation pressure of what they're using with their laparoscope. Any distal extremity, distal meaning towards the ends of your limbs or towards the end of anything you're talking about, if you're working on a foot, you don't necessarily need a lot of positive pressure to help that patient breathe. There's no inflated abdomen or inflated chest cavity that you're working against. For the most part, those patients are going to be okay breathing on their own or with just a little bit of supplemental positive pressure. And so in those cases, an LMA works great because we can allow a patient to do their own thing. They probably don't need muscle relaxant with the exception of certain orthopedic cases. And we can use different ventilator settings like pressure support, where we just give a little extra push at the end of their own inhalation to help them get a little bit more air. So LMAs work great in the extremities, endotracheal tubes, anytime we're working within a body cavity. If we're working in the head, obviously access to the patient's airway is a concern, and so you may see people choosing to opt more for an endotracheal tube as opposed to an LMA because it's considered a little bit more of a secured airway, whereas an LMA might pop out.
I noticed in the cardiac rooms they use the 8 a lot, like I replace the 8 a lot. They probably don't use LMAs.
We pretty much never use LMAs in cardiac with the exception of maybe a sternal wound debridement, where they're staying sort of superficial in the body. They're not going down into the chest. They're just kind of cleaning up things on the surface. And the reason we use larger endotracheal tubes in cardiac is because the patients are likely going to be intubated for a longer period of time. And so if they have any issues getting off the ventilator in the ICU and they need to be bronched, where somebody takes the camera down and washes them out and does a real therapeutic bronchoscopy as opposed to just a diagnostic where you're looking with the tiny camera just to look around. A real good therapeutic bronch needs a bigger lumen tube to accommodate the bigger scope. So we tend to use bigger tubes anytime we think somebody might stay intubated longer. Okay. So just to kind of review what we've already talked about. So negative pressure inspiration is normal. That's what you're doing on your own. Positive pressure is when we need to help drive the air into the patient's lungs for various reasons. Because we're fighting against something, because we've paralyzed the patient and their own body's not working the way it normally would. Or, you know, I guess another reason to intubate somebody would just be, you know, to protect against the air or other body fluids going in the wrong spot. So what I mean by that is if somebody's got a full stomach, or if somebody's got a lot of acid reflux, and we don't want stomach acid or stomach content to go in the wrong direction, meaning into the airway, we'll put an endotracheal tube down, because that cuff, although it's not 100% protective, can minimize you aspirating something from your stomach into your airway. So that's probably another real good reason to put an endotracheal tube as opposed to an LNA. So with that said, anybody here think of a reason why you might need a double lumen tube or a bronchial blocker, or why you might choose one versus the other?
We use the double lumens when they're doing like the thoracic cases, right?
Yeah.
Those.
Yeah, so if you're
Shut one
operating
side down versus the other.
exactly, yeah. So if you're operating on one side, you don't want it moving. One, because it's just a harder target to operate on, but two, you need to be able to see what you're doing. And so there's different strategies that surgeons use to be able to get good visualization. In the abdomen, again with laparoscopic surgery, they blow carbon dioxide in to inflate the abdomen to give them a bigger space and better visualization of what they're looking at. Often in thoracic surgery, you don't necessarily have to blow air in to get a bigger cavity, because you've got a rib cage. It's not going to expand. All you're really doing if you blow air in is squashing down the lung that's on that side, and that can have some pretty profound hemodynamic effects. So for the most part, you let a lung just deflate when you're working on that side, but to let it deflate, you need to stop ventilating it. You can't just stop ventilating the whole patient, but you can in most cases stop ventilating one lung, let it deflate, and just continue ventilating the other side. Some thoracic surgeons will actually blow carbon dioxide into the pleural space or the lung space to get better visualization. So it's not like we never do that, but for the most part, just isolating the lung, meaning breathing selectively for one side or the other, and dropping the lung that you're going to be operating on is what the surgeons need to be able to see what they're doing.
Why do they always use the left side?
Yeah, the left is usually more.
That's what the whiteboard's for. All right, so as far as basic lung anatomy, let's just start way up here.
Take your heels up.
So we're gonna pretend those are vocal cords right there. Cool, you can come on in here if you want. You guys match up with the anatomy. So if somebody, just a tangent for a second, if somebody throws up as they're going off to sleep and aspirates, you know, that gastric content into their airway, it almost always goes down the right side, and that's because of the anatomy. It's a straight vertical shot, so if I vomit, it's going to go with gravity right down, less likely than to go over to the left side. So when somebody aspirates, they almost always get a right-sided pneumonia related to that. So when we're trying to isolate a lung, we need to use the right tool to isolate it. So which side, right or left, has 3 lobes of lung, as opposed to 2, which the other side has? Any ideas? So the right side has 3 lobes, the left side has 2 lobes, and that's part of the reason the anatomy is a little bit different. So let's oversimplify it, but there's an upper and there's a lower. We'll just keep it simple. So a left upper and a left lower. And so we're looking at this like I'm standing here, okay? So this is left side, this is right side. Left, right. Left upper, left lower. Pretty consistent. Most people have that sort of setup as far as anatomy on the left side. On the right side, you've got 3 lobes. So you've got an upper, you've got a middle, and you've got the lower. So when you put a double lumen tube down, it doesn't matter which side you're operating on, you just need to make sure that you can occlude the major sort of takeoff to either side. So right here or right here. If we really want to isolate breathing on one side or the other, we need to make sure that we can sort of consistently occlude this to typically we do that with a balloon. So if we're using a left-sided tube kind of looks like this. You've got the tracheal side with an opening, and you've got the bronchial side. This is a bronchi. This is the trachea. You've got a bronchial side. It's a little bit longer that actually goes down that side. So when you put the tube down here, you've got the bronchial lumen sitting beyond this bifurcation. And then you've got the tracheal side that opens up right here, okay? Excuse me. So there's two balloons on a double lumen tube. There's a tracheal balloon, which just allows you to isolate everything that's above the airway from everything that's below. So if I, like a normal single lumen breathing tube, I inflate that balloon so I can push positive pressure air in without it all leaking out. That's what this is for. The balloons that are down here, depending if you're using a left-sided or a right-sided tube, are just to isolate one lung from the other. So with a left-sided tube, it's really easy to place this balloon because just about everybody has consistent anatomy right here. Okay? It's almost always the same. And there's a fair amount of distance between where this bifurcation happens and where the takeoff of the left upper lobe is. So it's really rare that you would be too deep and missing that lobe when we're trying to ventilate it. The right side, there's a ton of variability. So the right upper especially might come off the trachea. Might come off right after the trachea bifurcates. It might come off down here. So there's a lot of different places that the right upper lobe can be. And so if we use a right-sided double lumen tube, which just looks the opposite of the left, bronchial lumen side, tracheal lumen side, where you're blowing the air is right here. You've got a balloon to include. If the right upper comes off up here, we've missed it. Okay, so we're trying to drop that lung or isolate that lung. You're still going to have a lobe that's blowing up in the surgeon's face. Okay, or if we're working on that lobe, we're still going to be blowing air into the operative field. So the number one reason we use a left-sided tube is because it's easier to place. And to be more specific, the reason it's easier to place is because we always have to consider the takeoff of the right upper lobe. If you look at a regular, just single lumen breathing tube, there's always a hole right there called a Murphy's eye. And the idea is that if your tube's a little bit too low, say, the tip of your single lumen tube is right here, your kind of right main stem, that Murphy's eye is still going to allow you to get air up into that right upper lobe. Okay? There's a lot of subtlety to the airways that we're using that have specific reasons related to anatomy. So again, we would choose a double lumen tube if we had to breathe from one lung or the other, okay, and selectively do that. And the way that we, isolate them is by inflating these two cuffs. This cuff allows you to blow air down into both lungs. This cuff allows you to stop breathing on that side or selectively breathing on that side. The other thing to talk about, I got the eraser, is how the airways are attached to our ventilator. So if you open up any of those boxes up there,
I think she'll separate it. Yeah, sorry, Thursdays are tough sometimes. Couple things. I got killed. Or was he just said to show you? Yeah. Zero, whatever. Or just put it on the desk. Yeah, I'll do it. Thanks, man. Appreciate that.
Then you put these two clear plastic ends onto the end here. This end.
You know.
Let's just push right onto the end. The other thing, when you're working with airway stuff, having seen it and gotten your hands on it is super important to understand how it works, because especially with bronchial blockers, we don't use a lot of them, and so you'll see people have gone through their whole residency and used a blocker maybe once or twice. And so it's not uncommon to have people calling you guys with questions to be like, all right, there's something wrong with this thing. Well, there's nothing wrong with it. You just haven't used it in a long time. You're probably not familiar with the one that we have at this hospital. All right, so this gets connected to the ventilator. Okay, fresh gas flow goes this direction, and if you don't do anything else, it just blows down both sides of the double lumen tube. We've already opened up this kit. I'm just going to use it. So a couple things to talk about. 41, that just has to do with the size, okay? So in terms of sizing a double lumen tube, somebody full size, I'd put a 41 in. Somebody your size, I'd probably put a 35 in. So an average sized man is gonna be a 39 or a 41. Average sized woman is gonna be probably a 35 in most cases, sometimes a 37 if they're a little on the taller side. And rarely we'll use the smaller size. I think a 32 probably the smallest up there. I think they go down to like a 28 maybe, but you guys would know better than I do. I never use the smaller ones, but the size is the first thing, and then choosing which side you want to use, right or left. So this is styletted. Take it out of the box. The stylet is going to go down the bronchial side because that's the most distal port on this thing. It's the one that goes furthest down into the airway. And it's got this natural curve at the end, but you'll see most of us exaggerate it a little bit because these are big tubes and it's sometimes hard to get it into the mouth where you actually want it to be going towards the vocal cords. So this is sort of a weird curve here, but typically what you'll see us do your laryngoscopy, we're going to come in this direction, and then we're going to rotate the bronchial lumen, which is the blue lumen, towards whatever side the type of tube is. So if we're going to the right, we're going to rotate it to the right. It's a right-sided tube. If it's a left-sided tube, we're going to come in like this and then rotate it over to the left, just so that the bronchial lumen ends up on the side that we're intending to be on. So let's say we've placed this. We went in, put it through the vocal cords, rotate it over so it's sitting on the right side. This connector, doesn't matter which side you hook up either side to, goes on like that. Okay, so they're just sort of pushed on to these connectors here. So this is sitting in a patient, this is connected to your ventilator. Say we want to selectively ventilate the right side with a right-sided tube. First thing we're going to do is inflate the tracheal cup, so we actually have the ability to drive positive pressure into the airway. Second thing we're going to do is inflate the bronchial cuff, so that we've now isolated right from left, okay? This just occludes the trachea so that we can blow air in. This balloon separates right from left. So if we're going to work on the right side, we don't want that side moving, right? So we do two things. We pop this open on the right side, the bronchial side, so that air can escape. And then we put a clamp right here so that we no longer are driving air in. A lot of people you'll see putting their clamp down here, and those are people who don't always understand what they're doing or are confused as to which side they're working on. But if you clamp down here, that lung's going to stay inflated because that air that's in it already has no way of escaping. Okay, so you pop this open to let air out, clamp this here so that you stop blowing air in. All right, if I wanted to isolate the left side and stop ventilating it, I would just close this, take the clamp off, move it to this side, and let this side deflate. Okay, you can see the right-sided balloon is a little bit different shape than a left-sided balloon. It comes off at sort of an angle with the intention of trying to allow more room below the balloon for the takeoff of the right upper, whereas the left-sided balloon is a little bit more uniform, sort of more oval as opposed to kind of off at an angle. Again, just so that you can continue ventilating that right upper lobe. So why would we select this over a bronchial blocker? Well, it's easier to place. It's more reliable in most cases in terms of getting good lung isolation. And it's a little bit bigger lumen most of the time than when you have a balloon sitting in your single lumen tube. And it allows the lungs to deflate better. So when you use a blocker, which I'm not going to take out of the case here, a blocker is not designed to breathe through. It's just really designed to occlude an airway, one side or the other. Okay, so like what we were doing with this balloon down here to isolate one side from the other, you take this device through a single lumen tube, feed it through, put the balloon where you want it, and inflate. All of that's very similar to a double lumen tube. The only thing that really is a challenge with blockers most of the time is getting the lung that you want to work on to deflate. Because when you're occlusive here, there is a small port through the center of this that you can either aspirate on or hook to suction to get that lung to deflate, but it's much smaller, so the lung doesn't deflate quite as reliably. So surgeons don't really like these very much because it doesn't give them quite as good of a field of view, because the lung doesn't deflate out of their field of view quite as quickly. Okay. So why do we use these? Well, most of the time, it's because we're concerned about being able to intubate somebody, so difficult intubation. Oftentimes it's easier to put a single lumen tube in than a double lumen tube. Or we're nervous that if we extubate, we won't be able to re-intubate. So after a heart case, let's say we're doing a thoracoabdominal aneurysm, big chest case, multiple hours, lots of fluid shifts, lots of swelling of tissues. A lot of people get nervous about using a double lumen tube in those cases, even though they might need lung isolation, because at the end of the case, we don't want to send that patient up to the ICU with a double lumen tube because they don't use them up there, so they're not familiar with them, and that sets us up for mistakes being made. And so at the end of those types of cases, if you had been using a double lumen tube, you'd want to switch to a single lumen tube before you send them up to the ICU. So, yeah.
Is that why in pediatrics they use the bronchial blockers instead of dual lumens for intubation reasons? It's simpler?
Maybe the case. More often than not with pediatrics, it's just a size thing.
Okay.
So there's not a lot of really small double lumen tubes that would be appropriate for the pediatric cases that tend to need lung isolation.
Okay.
So a congenital diaphragmatic hernia on a newborn, there's no newborn size double lumen tube. And so what you do is put a single lumen tube in, and you can either put the bronchial blocker through the tube, or in pediatric cases on the side of the tube, actually go around the outside of the balloon and then inflate the balloon and use it that way. So in adults, it's mostly because we don't want to exchange the tube at the end because we're worried about losing the airway, or up front because it's a difficult airway and we don't think we're going to be able to get a double lumen tube in. Those are probably the two most common reasons why we use a blocker over a double lumen tube. Again, people don't use these very often. This is another thing right here that's useful to get familiar with. There's 3 ports. This one hooks to the ventilator. This one hooks to the patient. So if you ignored these two, this is just a normal sort of L connector that allows you to ventilate a patient.
Mind showing that this way, Justin? This way?
Yeah, sure. So to the patient, to the ventilator. And there's 2 additional ports. One that's got a sort of a soft plastic diaphragm that you can put something through, and it kind of gives you a little bit of an occlusive seal around it. And then this thing here that you can pass another thing through and tighten it down so it doesn't move. Okay? So this one, this straight vertical shot, is where you put your fiber optic scope. Okay? It's a straight shot, so you don't have to bend the scope, and it seals around the scope so you can move it in and out without losing all your air that you're trying to blow down into the patient's airway while you're manipulating it. This is the side that the blocker goes through. And the reason it's got this little connector that you can tighten down is so that once you've got the balloon where you want it to be, you crank this down and then it won't move. Okay? So it's designed to be loosened up while you're placing it, and then crank it down so that it doesn't move once it's where you want it. Probably the most common thing people do is screw up these 2. Okay, so they'll put their scope down here and their blocker down here. They get it where they want it if they're lucky, and then they let go and it moves out of position. The other thing that they'll do is they'll hook this up to the patient before they, before I even go there. There's a little loop at the end of this bronchial blocker. Okay, if you guys have looked at that, there's a little basically thread at the end with a loop that if you pull on this white connector at the top, it cinches that loop down. And so it's designed for you to put the fiber optic scope through that loop and then cinch it down so you can drive the scope and drive the tip of the blocker wherever you want it to be. So you'll see people connect this to a patient and be ventilating them with this connector, and then try to thread the scope in, thread the bronchial blocker down, and do it all like looking at the camera. Try to just like drive the scope down through this little circle. Much easier, and you guys can even give them this tip if you're watching somebody really struggle like that. hook all of this stuff up before you ever hook it to the patient. Okay, so take this thing out, put the blocker down here, take a fiber optic scope, with your hands, take the end and put the loop over the end and tighten it down, and then hook it up to the patient and try to drive it. When somebody's trying to like thread the needle, you know, on a camera, you watch them struggle for 10 minutes and they never do it. Whereas if they just took it off and just by hand did it, it takes 2 seconds. Okay, so that's a really common mistake that we see. There's other little connectors in here, so if you wanted to put suction on this blocker to deflate the lung on the side that it's pointing at, you have to actually take the wire stylet that's in the inside of this out. So this little white piece, pull the white piece off, the wire that's going through the center of this comes out, and then you have a channel in it that you can put suction on, or you could blow oxygen into, okay? So these connectors are designed to help you with that. So this is a connector that you could use to hook up to an oxygen supply or a suction, and either blow air in or suck air out. And this is another thing you could hook up to an ambu bag. You could actually ventilate somebody through this. Not effectively, but you know, this life or death, you could get some oxygen in, you could do that. So yeah, that's kind of where we're at. Questions so far?
Oh, very helpful.
Okay, so big picture stuff, intubate somebody when you need to use positive pressure ventilation. We talked about why you would use positive pressure ventilation. LMA is only used for your convenience. It's not, there's nothing about an LMA that's designed to be medically necessary. It's all about what's easiest. So if the patient doesn't need muscle relaxant and we think it's going to make our lives easier, we'll use an LMA. If we think somebody's going to be hard to ventilate, even, you know, for something like a toe surgery, we're not going to use an LMA if we think it's going to make our life harder. So if somebody's 500 pounds, probably not going to put an LMA in, even if we're working on their pinky toe, because it's just going to be hard to ventilate them with the LMA because we can't blow as much positive pressure.
LMA sits above the vocal cords.
That's right. Yeah. So an LMA, we don't have it up here anymore. An LMA would sit above the cords. The tube goes down into the airway. Okay. So positive pressure, negative pressure, endotracheal tube, LMA, and then lung isolation, really for the surgeon to be able to see what they need to see, and for us to selectively ventilate one side versus the other. And then double lumen tube versus bronchial blocker, based on ease of using the double lumen tubes, ease of getting the lungs to deflate, versus these, when we get scared we can't intubate, or wouldn't be happy if we extubated. Okay? That's kind of an oversimplification, but all right. Hopefully that was helpful, guys.
That was awesome. Yeah, thanks, Justin.